All right, we're going to start this week talking about culture. And, no matter where you work as a nurse and what kind of nursing you get into when you graduate, culture is always going to be a core concept that you bring into whatever patient situation you're dealing with. And it may be that your patient is of a similar cultural background to you and a similar belief system, and then that interplays with how you relate it to the patient. And it may be that the patient has a different cultural background or belief system than you, and that interplay has an impact on how you practice nursing. And so it's very important that as the beginning of our nursing education, we're learning about how culture impacts how we interact with patients and how culture impacts patients' own health beliefs and how they want to be treated as a patient. So go ahead and get out your textbooks, because remember, this is a study along with me type of reading. So you're going to have your textbooks out, have your pen and notepad ready and some highlighters, and also have those concept study guides, because I'm going to ask you to be filling that out as we go through the reading. Now, here are your objectives for this video. We're going to complete that concept study guide, and you're going to start building up these concept study guides that you'll have to use and reference throughout your full 2 years. You can find that on your Blackboard course. And then you're going to make sure you can answer the rest of these questions. And if you can, at the end of this video, look back and answer all of these questions on your own, then you've gotten what you needed from the material. So I would encourage you to pause here and either take a screenshot of this page or write down these questions. And then as we go through the material, be answering these questions in your notes. That way, when you go back to study for your midterm and final, you'll also have a really nice study guide that you made for yourself. So go ahead and pause, take a screenshot, or read through these right now. So let's go ahead and get into the definition of culture. This comes right out of your Giddens text. Culture is everything that we share from either a particular language or people who live in a specific geographic region, and people who live in those areas or share that language are going to have certain norms and beliefs and roles and values, music and food, and all these things that kind of are a shared collective of a certain people group. There's some key terms from your text that you'll want to know. So enculturation is a process which a person learns the norms, values, and behaviors of another culture. So when I was 18, I had studied Spanish for 5 years, and I did a study abroad in Costa Rica, where I lived with a Costa Rican family for a summer, learned the local salsa dancing, and went to a local Spanish language school, and got to really be familiar with the farmers markets and how to take the buses and learn the music. And all of that is an example of enculturation, when you are learning someone else's culture and norms and values and beliefs. Acculturation is a process of acquiring new attitudes, roles, customs, or behaviors. So one is where you learn them, but they don't really become yours. And acculturation was you actually take those in to be your own. So the example here is an immigrant from China develops a preference for Western food and music. Assimilation occurs when a person from a different culture is so ingrained in a new culture that they start to actually strip away their original culture and now identify with the new culture that they live with. And biculturalism is someone who acquires identity from two cultures. So I had a friend in high school whose mom was of Christian faith and her dad was Jewish. And I was always so jealous because their family got to celebrate both Hanukkah and Christmas in December and got gifts for both. So as a child and teenager, I thought that was pretty cool. That was an example of biculturalism. Now, ethnicity and race often get confused, and they both have to do with your ancestral bloodline, but one has to do with how you identify from shared values and beliefs, and one is just the physical or the biological characteristics. So an ethnic identity or an ethnicity is not only your bloodline, your ancestral biological characteristics, but also those common cultural beliefs that you have, while race is specifically just about the physical or biological characteristics. So certainly culture not only impacts our music and food and holidays, but also how we look at health and wellness and how we approach our health in the healthcare system because of that. And I just want to say all of this you have to take with a grain of salt because every patient is unique and they all come with a cultural background, but their own personal identity as well. And so you want to be aware of cultures and general cultural beliefs, but then also be asking your patients specifically about them so that we're really providing patient-centered care and not just assuming things about their culture. When I worked in my previous hospital, I worked with a coworker who was Hispanic, but didn't speak any Spanish. And it always really bothered her when patients would just start speaking Spanish to her just because they assumed that she must speak Spanish. And so we just don't want to assume things of our patients too. We want to be informed. So when our patients do tell us something about their culture or about their cultural beliefs, that we have enough of a background to be able to accept and provide care based on those things, but also not assume things of our patients. But culture certainly does play into how we look at our health. And so the scope of culture in healthcare includes our casual beliefs about health, how we express illness. Some cultures tend to express illness very loudly and dramatically, and others are very stoic. And both of those can be an expression of the same symptom, like pain, but it can be expressed very differently. How you, what kind of symptoms you have or how you describe those symptoms can change based on culture. And then certain taboos, meaning things that you would never do or never accept as part of healthcare. So in order for us to provide culturally competent care, we have to first look within and consider our own culture and how we approach healthcare based on that. And I think the importance is to recognize we all have rose-colored glasses on, right? We all have a world view that we see through our cultural lens. And so we need to recognize what is that worldview that we seek healthcare through so we can take those off and see be able to understand our patients from their perspective and recognize that our perspective and our view of culture and how it pertains to health may be different than them. So think about how your cultural norms and your own cultural beliefs impact how you provide care, even the way that you think of your own health. And how can these cultural norms influence nursing and healthcare delivery? So things like our casual beliefs about illness, the symptoms and expression of illness and taboos, how do those impact nursing and healthcare delivery? So here's a couple things we know about culture. Culture is learned. It is something you learn as a child and you grow into as an adult. Culture is changing and adapting, and it's a set of shared beliefs, values, and behaviors. And if you think back into your own childhood, I'm sure there are many holiday traditions or foods or activities that you do at birthday parties, and those are all learned activities that are part of your culture. So there are some broad categories that are always involved in different cultures. So some cultures value the individual, like the American dream and finding your own path, versus the collective, where you're thinking more about the family and what your impact of your choices has on your larger family. The distance of power and gender roles. What is the male role? What is the female role in a culture? Short or long-term orientation. So is your culture planning for the future, or are you much more focused on the present? And then of course, religion and religious beliefs can also be a part of learned culture. For this chapter, go ahead and skip the theoretical link section on Giddens on page 31. It's just not really going to add much to our conversation today. So a core competency for nurses is that we're able to provide culturally competent care. So what is that? So first of all, it's an expected component of nursing education, and it's expected of you as a professional nurse when you graduate that you're able to provide cultural competency. And so cultural competency requires an acceptance of a patient's health beliefs, and also requiring an adaptation to meet the unique needs and perspectives of the individual. And in order to meet those unique needs and perspectives, you have to have a basic knowledge of a specific culture. And so we're not only teaching you to accept And we're not only teaching you to adapt, but we have to teach you some basic knowledge of cultures in order for you to be able to adapt and meet the individual needs. And in your Davis book, they're going to be talking more specifically about types of cultures and religious beliefs that will help you navigate this better. So we know we should provide culturally competent care in nursing, and that we need to be accepting of wherever patient is and of their cultural beliefs, and that we need to adapt our own nursing care to meet those needs and meet that patient where they're at. But sometimes we don't get this right in nursing. And oftentimes, I don't think it's because nurses are dumb or lazy, but there are certainly barriers. And so we want to discuss those barriers that are barriers to culturally competent care, so that we can recognize them and discuss and think about how do we overcome that. So here's a list of barriers to culturally competent care from your Davis text. And I think if you had to summarize this list in a few words, it comes down to ignorance and lack of empathy or understanding. And so I think our challenge is to strip away our own bias, learn as much as we can, and question our own hearts in terms of what biases we might have and stereotypes or discrimination we might have that would prevent us from really seeing a patient for who they are rather than seeing them through our own biases. And of course, there are some vulnerable patients that become kind of their own subcultural groups in our communities. People who are poor or homeless, the mentally ill, people with physical disabilities, the young or the very old, so ageism, right? And even some ethnic or racial minority groups are more vulnerable to poor healthcare based on their own cultural beliefs or their kind of the subculture of who they are. Oftentimes, if people are homeless, they get worse care just because they don't maybe smell as good or look as presentable. Or the mentally ill sometimes aren't believed in healthcare because they're labeled as schizophrenic or they're labeled as anxious, but really there might be something else going on, but we dismiss it as healthcare providers because we don't see past this cultural shell. And so just again, I think in the age of social justice and people really looking introspectively at their own hearts and seeing how we can all grow in our acceptance of other cultures and not only tolerance, but recognizing the beauty of other cultures and the value that we have as a diverse population. And that plays into how we perform as healthcare workers and as nurses as well. So just to be aware that these vulnerable populations are vulnerable for poor healthcare outcomes because of the subculture that they're in. And we want to make sure we do everything we can to provide individualized, patient-centered care. So in order to understand someone's culture, we have to do an assessment. It's the first step of the nursing process, assessment. And so what assessment data do we need to provide a cultural assessment? Well, there's a couple of things. We want to know where they're from, their location of origin and their family, their communication in terms of both their nonverbal and their verbal and what language they speak, about their personal beliefs about health and illness and how those are affected by being part of the modern Western healthcare system, and some of their daily practices that they practice at home. You know, when we do a medication reconciliation, and so we're writing down all the patient's medications that they take at home, we're asked to not only write down what prescriptions they take and over the counter, but herbal supplements as well, because people have different herbal supplements that aren't FDA approved, but are part of their culture and they find great value from. But they can have interactions with other medicines that may be prescribed. And so it's important to have a full understanding of a patient's medications, including any herbal supplements or health practices that they might do at home. So how do I care for a patient who speaks a different language? I'll be honest, this is definitely a barrier to providing healthcare to someone. When you're using an interpreter, you can do the best you can, and there are always going to be some gaps or some barriers to excellent communication, and because of that, we need to do our darndest to make sure that we are communicating well and providing the patient what they need. And so that is through the use of an interpreter. So medical interpreters actually have to have specific training and credentialing to show that they can speak in medical terms. An interpreter, there are different ways that people use interpreters in the healthcare system. Some hospitals are going to use a live interpreter in person. Now, hospitals who have a specific patient demographic that they see a lot of that speaks a specific language, they may have language interpreters on site, while others may use an internet or computer-based translation software. The place I just worked at, we used to have a phone that had 2 different headsets, and we would call the interpreter, and then the interpreter would be speaking, and then the patient would have the other headset, and that's how we were able to communicate. And there's a lot that are on computers now, which is really nice, because then you can see the interpreter and you can get those non-verbals, which are certainly a part of communication. And then the Davis text talks about the difference between an interpreter and a translator, where an interpreter is really translating the meaning of the phrases and the words and the sentences, and the translator is just translating word for word. And so an interpreter is what we really need to provide the same contextual meaning to what we're saying. And medical interpreters do have to be certified, so that if we are doing some kind of procedure or explaining something to a patient, we need to make sure that that interpreter has the right credentials in order to be able to explain those appropriately. I don't know if you heard about it, but a couple of years ago it was on the news that some big government official did a news, like a teleconference to explain what was going on in their state or their city, I don't remember. And they had hired an interpreter or sign language interpreter last minute. But it turns out it was a complete con. This lady didn't know how to speak sign language, and they were on the news broadcast, and the public figure was doing his speech, and this lady was signing next to him, and then the deaf community came out and said, that's actually not sign language at all. Who in the heck did you hire? And so it's really important that we know that the interpreters are providing the right content to the person. So when you do use an interpreter, the interpreter will have some kind of identification. So it's usually an interpreter number. And so you always want to document what interpreter you used, because that communication piece is really important. We'll talk about interpreters more, but just to give you a kind of a quick overview, when you're using an interpreter, you're going to still talk to the patient. You're not going to be talking to the interpreter and say, please tell Mr. Jones that he's going to have surgery. You're going to say, Mr. Jones, you're going to have surgery, right? You're speaking to the patient, you're looking at the patient, even though the interpreter is still going to be speaking. And I've seen nurses really struggle with that point. So you want to make sure that you're still talking to the patient. The translator or the interpreter is just kind of this extra third party, but you're focusing on the patient, talking directly to them when you're using the translator. So we know we need to provide culturally competent care. And we know that that means accepting a patient's culture and their cultural background and beliefs, all of their beliefs about health and illness and how they express that, any taboos that they have, any health practices that they do at home. And we know it means adapting our care to be culturally competent to meet the patient's needs. And we know that that requires a basic knowledge of the kinds of cultures that we're going to see in the places that we work. But how do we grow in it? We know we need to do it, but how do we grow in it? There are 4 different interrelated constructs that help us develop this cultural competency. And one of them is knowledge, cultural knowledge. So we talked about how in order to adapt, we have to be able to have a cultural knowledge, but there's 3 more that we need to add to our list. So not only do we need knowledge, cultural knowledge to adapt, but we also need a desire. So we have to want to learn, and we have to want to provide culturally competent care. It doesn't just happen by accident. We need to have self-awareness. Awareness of our own biases and our own cultural beliefs and our own understanding of health, to understand how that impacts the advice or the care that we might provide. And then we have to have cultural skill. And that's our way of applying the knowledge that we learn about their culture. And so if you have to learn anything about cultural competency today, it's that cultural competency is this acceptance of a patient and all of their health beliefs and their cultural beliefs and their values and how that really impacts who they are, because that doesn't just go away just because they're on the exam table and come to the healthcare center for your assistance. And then we need to adapt in order to provide that culturally competent care. We're going to adapt in making sure we understand their culture, that we have a desire to want to give good culturally competent care, that we have a self-awareness of our own culture and how that plays into the way we provide care. And then finally, we use the skills that we need to provide that culturally competent care appropriately. And if you like acronyms, which apparently healthcare loves, you have this live-learn model that's in your Davis text that helps you continue to develop this cultural competency. You can go ahead and read through that in your text as well. But the key point here is if there's only one intervention you could do to improve your cultural competence, it would be to routinely ask patients what matters most to them in their illness and treatment, and making sure that we keep that at the center of everything we do as we provide that patient care. And so your Giddens text has always has this nice concept map of how the concepts interrelate. So around the concept of culture, certainly spirituality and family dynamics, we talked about gender roles within family, how people cope with stress or what stressors are involved and how they manage those, how they express stress can be part of a culture. How you communicate, not only in your language, but with your nonverbals, what's appropriate to communicate in your culture, what's not. And then how you express fatigue and mood and affect, how your ethics, remember we talk in ethics about how ethics are shaped by things like culture. So culture and ethics go hand in hand. And then unfortunately, health disparities, we're going to be talking about more in class, but there are certain cultures that have health disparities, which means poor outcomes, unequal to the rest of the nation, just based on their cultural background or geographic location. And so health disparities and culture really interact as well. There's a couple of exemplars in your Giddens text. Go ahead and take a look at those. It's things like how people's individual healthcare practices or beliefs, the family roles within a culture, and then patient-provider communication and how that interplays, and how if you're of the same cultural background, that has a way that plays into the way you interact with the patient. And if you're of a different cultural background, that interplays with how you interact with the patient. And communication is huge in what we do, not only for cultural competence and patient-centered care, but for safety and making sure that communication is clear so that patients get safe care as well. So take a look at those in your Giddens text. That's all I have for you on culture. We'll be discussing this more in class, but just remember, you're going to want to have cultural competency by accepting a patient for where they're at and adapting our care for that patient based on their cultural beliefs. And we're going to do that through a desire, a want to change, a want to provide culturally competent care. We're going to look at ourselves and do self-reflection to see where we're coming from and what our beliefs are. We're going to make sure we understand that culture, and then we're going to implement that with skills. See you in class.